Good afternoon, everybody, and welcome to the Parkinson's Academy webinar on good practice in commencing and changing Parkinson's medication. We're very thankful for the support from Profile in sponsoring this webinar, and very grateful to the speakers as well. So we will start this afternoon session with myself just giving a quick housekeeping, followed by Viv and then Archie, and questions at the end of both of their sessions, please, using the Q&A function at the bottom. And then we're delighted to be welcoming Hannah Martin at 4 o'clock to do a little bit of a roundup about her experience on looking after people with Parkinson's in the new virtual world. And again, I ask you to put any questions to her using the Q&A function. And just quickly letting you know that we've got further masterclasses happening for Parkinson's next year. We may even have somebody like Archie popping up on those to add his wisdom and great knowledge. So please feel free to come to those. So I will ask now Viv to start this afternoon's session. Viv.
So I was asked to do just a bit of a session about commencing Parkinson's medication and hopefully how to do that well. I'm Viv, I'm a pharmacist by background, and I'm fortunate enough to work with Archie in the movement disorder team at South Tees. I've worked previously with the Neurology Academy and Parkinson's UK and just received some expenses for that. And I'm also a committee member of the PDSPN, which is the Parkinson's Specialist Pharmacy Network, and our inaugural conference was sponsored by the pharma companies listed, and I don't have any financial interests or any conflicts of interest to disclose. So I thought today would be more of a how-to rather than a specifically what to start. I think we're probably all aware of the NICE guidance. It's been around for a while. I guess in terms of starting a medicine for the motor symptoms of Parkinson's, we've got a bit of a choice between sort of levodopa, dopamine agonists, monoamine oxidase, B inhibitors. When I have a chat to, for example, one of my colleagues who works in cardiology, I think it's probably relevant to think that the prescription of Parkinson's medication is a lot less formulaic, for example, or a lot less linear than in cardio. And I think there's a lot of sort of bespoke prescribing for the individual. In terms of which medication to start, I think it's a good idea to ask ourselves which symptoms are we trying to treat, and also what sort of an impact is that having to the patient. I think quite often I'm surprised that the symptoms being described by the patient are perhaps in a different order of priority than I might have guessed had I not asked. So we're thinking about, is tremor really prevalent? Have we got problems with gait? Have we got problems with just general sort of slowing down of motor function? Have we got problems overnight? And we're maybe thinking about maybe needing to give some treatment that's going to last the 24 hours. I guess it's relevant to say as well that we know that not all tremor is going to respond well to the medicines we use for motor symptoms in Parkinson's, but obviously sometimes it does, and if we were going to go down other routes for treating tremor, we do need to have fully explored the medicines that are available. And then also thinking in terms of future planning for the person in front of you, what are we trying to avoid? You know, are we being really careful about impulse control? You know, are we having that chat, you know, right at the beginning of treatment, that sometimes these medicines, particularly at bigger doses, can cause problems. We're going to ask you funny questions, and we're going to ask your family member, you know, if there's been any sort of changes to your sort of preferences, or are you doing anything funny? And you know, if you are starting to, any of those things are starting to creep in, you know, give us a ring, because sometimes it just responds to a dose reduction. You know, are we thinking about perhaps some of our patients that are diagnosed with Parkinson's at a younger age and are going to live with Parkinson's for a long time? Are we just being careful about trying to avoid dyskinesia in that group? If possible, you know, are we wanting to give things that are perhaps levodopa sparing? And not to say that we wouldn't use levodopa in that group, but we just don't want to get up to really big doses really quickly. Or are we looking at a group where perhaps hallucinations could be prevalent? And then, yeah, I guess getting to know the person in front of you about, you know, what's important to them. What does life look like for them at the moment? Are they working? Have they got, you know, a very active family life? Are they looking after grandchildren? You know, what aspects are perhaps going well at the moment, and we want to preserve those. You know, for some people, their job might be dependent on them still being able to drive. So we want to make sure that we're not causing, you know, large amounts of daytime sleepiness with sort of not optimally prescribed medication. Okay. So thinking about person-centered care, we really need to know what other comorbidities a person with Parkinson's might also have, and also their sort of illness experience and their sort of beliefs about medication. It may be that the person in front of you has done some reading, maybe even at the point of diagnosis, they've had a bit of an inkling as to what's going on, and they've read around a bit. You know, what do they believe about the treatment options that they've read about? Do they see them as kind of the only way of managing this? You know, do we need to be setting our stall out early on, explaining that just using the medicines is not going to give us the best management of Parkinson's? It's going to be one important aspect, but it's not going to be that we're going to ever increase Parkinson's medicines. Have they sat and read, you know, the side effects listed in the information leaflet? Quite often it's pretty horrifying is the feedback that we get from our patients, and enough to put them off taking anything at all. So sometimes having that sort of you know, that collaborative discussion about, you know, what are your preferences and what's your previous experience with medication, what are you expecting in terms of outcomes with this medicine. Obviously, it's important to consider other medication, both in terms of interactions. As pharmacists, we love Stockley. We can fully search that, but also most of us have probably got BNF app on our phone, so we'd be able to just plug in all the different medicines that a patient might be taking, and just check to see whether we're going to potentially run into trouble with interactions. You know, there'll be some that are absolutely, please don't do this, and there might be some that we just might need to warn a patient, if you feel like this, let us know and we'll come up with plan B. I guess the other thing to think about is the potential tablet burden that the patient might already have around their sort of other conditions, and that might influence their preferences in terms of further treatments. And then sort of thinking about, you know, asking your patient, what does your day look like? You know, what's going to suit this patient best? Is it a once a day medication or a 3 times a day medication? How's that going to fit in with their day-to-day life? You know, we've got some people who'll say, you know, whatever I need, I'll take it, and other people who are really not keen, for example, to take medicines whilst they're at work. How are they feeling sort of tablets versus a patch? I guess sort of our golden rules in our team is start at a small dose and increase slowly. We know that Parkinson's is going to fluctuate day to day and, you know, across the course of weeks. So generally any changes that we make, it's going to take a while for us to establish how well that change is going. And yeah, as always, we want to make one change at a time. So I'd always think about, you know, if we're thinking about if somebody's already on lots of other medication, do we need as a first step to maybe do some deprescribing before we add in a Parkinson's medication. But yeah, certainly not going in and making like wholesale changes. Moving on to communication. I often wonder, are we being clear? It's fantastic that we're copying letters to our patients. I do wonder what they might understand at first seeing you know, prescription given for Madapar 62.5 milligrams TDS. Their knowledge of abbreviated Latin might be a little bit rusty, even if they're aware that that's 3 times a day. It doesn't really give good information about what time of day to take it. Often the default might be to take the 3rd dose at bedtime, which might not necessarily be the most helpful thing if we're trying to improve function throughout the day. If we're using another medication, if we're say using a dopamine agonist at nighttime to try and help with nighttime symptoms, you know, have we specifically said, please take this in the evening? Again, you know, if it's Madapar, how does the GP know which form we want them to prescribe to continue the prescription? Often the default in a lot of prescribing systems will be tablets, and that's probably not what we want. We probably don't want dispersible tablets, we probably want capsules. So I just think it's worth thinking about, you know, am I being explicit in my communication? Obviously, we want to give patients as much information as possible. We want to give some verbal information in addition to some written information. We know Parkinson's UK have got a fantastic booklet that people are able to take away and read. Often we would, we've just about got these patient information leaflets rubber stamped within our trust, sort of just thinking about, right, well, these are the benefits of these treatments, these are the potential side effects. For example, if we were using levodopa and you felt a bit sickly, you know, that might be quite short-lived. You know, can you tolerate that? And let us know if things are not quite going right, and maybe having a condensed list of potential side effects for each of the treatments. Communicating with the GP, sometimes we'll use what we term a treatment recommendation form, so we can quickly fill that in clinic and the patient can go away with it, and either it's a request for the GP to add this to the prescription or to let them know that we've issued a prescription today, so that just at the earliest opportunity that they're aware as to what treatment we're giving the patient. We'd also obviously have more detail in the clinic letter. I think it's also important to make sure that we're always including some sort of parameters. You know, if I've said, oh, I want to start a dopamine agonist and I just want to increase it, you know, there'll be lots of different interpretations as to how far that titration might go. And we'd also include any details of any supply that we'd made. And the other place I think can be really helpful is getting in touch with the patient's community pharmacy, particularly with electronic prescriptions. Patients have usually got a nominated pharmacy, and sometimes they know them really well. You know, potential to do medicines use reviews with our patients and make sure that when we're changing medication, for example, if we've let the community pharmacy know what the change is going to be, they'll make sure that they have got that from the prescriber before they give the next prescription. I'd specifically get in touch with the community pharmacy if my patient had any kind of compliance device. These tend to be prepared way in advance. The prescriptions are written in advance, and then the trays are often made up a month at a time. So often if we don't communicate, it can be quite a while before those changes are actually seen by our patients. I think it's important to realise when we're starting medications, that's just the beginning of the journey. You know, have we done appropriate signposting to the relevant team members? Do our Parkinson's nurses know about these newly diagnosed patients? In our service, often they'll be bringing them back to newly diagnosed clinic just to see how things are going and make sure that they've got all the information that's needed. You know, do our patients know that we've got you know, neurotherapy team, physio, OT. Our physios run a moving forward course, which in happier times would have been face-to-face. But the plan is to deliver this remotely, about lots of aspects of self-care, you know, how to make the most of the medicines, you know, how to stay active and meet the team, you know, input from the OT, input from speech and language, etc. And, you know, are we promoting sort of mental and physical well-being? Parkinson's UK again has some fantastic links to all different grades of exercise to keep us moving during this challenging time. And yeah, just some information about what to do about non-motor symptoms. And I think finally, importantly, plans for, you know, when will the patient be seen again? We've got some fantastic nurses. So most people there, apart from our bottom right, those are our lovely nurses from our team. Often our patients are telling us that it's quite difficult to get in touch with the GPs at the moment. So I think it is particularly important that they're feeling supported and have somewhere to turn if they've got any questions or concerns. So we'll often be saying, give us a ring after a few weeks. Let us know how this treatment's suiting you. I've also got Rachel at the bottom right, and she's our secretary, and I think you know, a fantastic advocate for our patients to make sure that things are heading in the right direction. And if she receives a call from any of our patients, she would definitely get that acted upon. And then we've also got the Parkinson's UK care advisors. But on our clinic letters, we have both the number of our local advice line and the name and number of the local Parkinson's care advisor. Okie dokie. Thanks very much, folks. I'm going to hand over to Archie, who's going to do changing things up.
Thanks, Viv. So, I mean, following on a bit from what Viv was saying, I just wanted to talk a little bit about how we kind of approach changing medication. And like Viv was saying, we don't want to go into, and there's so many sort of iterations of what treatment you can use and how you add stuff in. And really, this is more about kind of processes, particularly given the extent of remote working we're doing. It's important to have your declarations. So those are mine. And basically no relevant financial interests and no conflict of interest to disclose. So I just wanted to take you through some thoughts I'd had about, I guess, over the last sort of 9 or 10 months, how we've been doing it in Teesside, what's worked well, what hasn't, and some sort of insights and things that I've maybe found useful or challenging. So I think the first thing just to say about, particularly with respect to consulting at the minute, is just to know your limits. We are all having to embrace slightly different technology at the minute. Some of this is really not new to us. And I think if you speak to any experienced Parkinson's nurse, they'll roll their eyes slightly at this idea of remote consultation, because basically that's what a telephone advice line is. And those have been running for a long time. At the minute, there's almost like this sort of hierarchy that's come into consulting, where you've got, you know, so your gold standard, which was really what we were mostly doing, which was face-to-face. And we are down to maybe about 30 or 40% of our consultations being face-to-face at the minute, which is a heck of a lot better than it was, but it's probably not where we would like it to be. Some of that is capacity at our end, and being able to safely have people in waiting areas that are designed to run for 12 or 14 clinics running side by side. Some of it is obviously kind of patient preference or carer preference in terms of risk and inconvenience for coming to hospital. We're all used to the telephone and we all do that. I think the bit that we're trying to find our feet with mostly is video consulting. And again, I think there are some pros and cons to that. I think there's some stuff that's difficult to do by phone that is just about doable by video. I think it's easier to do review appointments by phone and video than to do a new assessment. And I think, you know, I'm very, very reluctant to diagnose anybody by video with Parkinson's, except in exceptional circumstances. In terms of the video, I think the biggest challenge we have is that whilst your patient might have a nice new iPad and a decent Wi-Fi connection, the same cannot be said of the NHS computers, which are, you know, 15 minutes to switch on, and if they've got a speaker, it's it's like some sort of transatlantic delay. So I think we find the Attend Anywhere system a bit of a challenge, and it's not at all unusual for us to just basically bail out of that and phone the person on their landline and just finish off the consultation that way. There is a little bit of GMC guidance on remote consulting, which I think is pretty self-evident. And I put the link on there for anybody that wants to go and look at the document in any more detail. But really, remote consulting is fine if the clinical need is fairly straightforward, if you have access to the notes, if the patient has capacity, if you really don't need to examine them, and if you have a way of giving them the information they need. And I think all I would just add to that is, if you know the patient, I think that makes, and you've already got a good working relationship with them, and I think that's fine. I think face-to-face should be your sort of default if you're struggling to meet those sort of requirements in the main. I think the next thing then is, if you're going to do remote consulting and you're going to change stuff, it's probably because the patient isn't well and they're struggling with their symptoms. And therefore, whatever way you do it, it's useful to have a system. Quite a while ago, we were, and we still are, in fact, trying to develop a sort of a database, a structured assessment database for our movement disorder clinic. And a while ago, I sort of came up with a little screen prompt to make me slightly better in the outpatient department. So I'll just take you through what I put up on the screen when I'm thinking about changing a patient's treatment. So I always start with the medication. And I know the medical students think this is a bit of a weird way to do it, don't they? Because they have a kind of presenting complaint, history presenting complaint, that kind of stuff. But I always start with the medication. I want to know what drugs they're on, what doses, what times they take them, and I want to know if there have been any changes either to their Parkinson's drugs or to any of their other medications since we last saw them. And I think that's really helpful, because if I can work out when they take their medication, then I can work out how levodopa responsive they are to that medication, and I can get them to take me through their day remotely. You wake up at 8 o'clock. Okay, what are you like at 8 o'clock when you first get out of bed? Your first tablet's not for half an hour. You take it at 7:30. What's that first 30 minutes like? You've taken your medication. How long do you wait for it to do anything? And you can get a really good sense, I think, from those sorts of questions about whether this patient has one of these amazing night and day responses to levodopa, where they're like a different person after 20 minutes, or if actually they are one of those sort of patients that doesn't really have much in the way of response, or certainly doesn't have the kind of motor fluctuation that we look for. But you can also get a sense of when they're dyskinetic, if they're dyskinetic, and how that relates to their dose. You can get a sense of their mobility and balance quite easily, I think. And all of that comes from knowing about their medication. Like Viv says, I think the non-motor stuff's important, and often, not always, but often a bit less dopamine responsive. And so I just tend to do a sort of top to bottom tour of the body, starting up with the head, thinking like mood, sleep, cognition, visual problems, speech, swallowing, any problems with sleep, and on you go. And I put a few things down at the bottom that are really just my blind spots. And I think some folk will ask about pain and fatigue a lot. I sort of forget to do that. And it's often then at the end of the consultation, I think, oh, I've done that again. I've forgotten to do that. And there's a few other things about, I sometimes forget to ask about driving, and even after doing this for like 20 odd years, I still forget to do that sometimes. And then the DVLA form lands on my desk about 3 months later, and I think, how do I fill that in? And then it's a phone call to somebody, and that's time that you didn't have to spend doing that if you just asked. So this is my sort of template for a systematic review of Parkinson's, and that works in clinic, but I think it works fine in a more remote fashion as well. And I think if you've got a structure, then you can stick to, then it kind of keeps you on the straight and narrow. I think my children are having a tantrum about Minecraft in the background. Sorry about that. Next thing then is just a little bit about getting the facts straight, and it comes back to that idea of knowing your limits. Actually, in some respects, remote consultation is a bit easier to get the medication doses, I think, sometimes because the patients have it in the house with them. Whereas often people will come to clinic with just, a little yellow thing and a white thing and a a blue and pink thing in a little in an egg cup or something, and you're like, I don't know what to do with that. Viv would know what to do with that, but I don't know what to do with that information. And I think the summary care record is a really good way of remotely accessing good information about their medication, and I find that incredibly useful. I'm not sure that this infographic is entirely representative of my experience of summary care record. I'm not sure I've saved 29 minutes per consultation. Looking at a summary care record, that's a long consultation if you save that much time. But I do think the summary care record is really helpful and allows you to avoid some pitfalls, particularly for prescribing a new medication that might have an interaction with something that the patient hasn't mentioned to you. So I'd say I find that increasingly useful. And then the last thing, and again, it kind of covers a little bit of what Viv has already said, is about how are we documenting what we're doing at the minute. Now, we're a bit of a Luddite system at South Tees because we still have pen and paper, and most places, I would say, are electronic records, or at least the majority now, and probably also have electronic prescribing. That's definitely not where we're at the minute. But basically, if you didn't write it down, it didn't happen. And so I think our Parkinson's nurses are dab hands at this with their telephone consultations and kind of keeping a contemporaneous record of what they're doing. But I think certainly as doctors, maybe we're a little bit less meticulous about doing that, and we'll sometimes give a bit of advice over the phone or by email, and it doesn't make it into the notes, it doesn't make it into the clinical record. And that's a recipe for disaster, I think. So we do have to be careful about physically documenting the advice we're giving. If it didn't happen, if you didn't write it down, it didn't happen, and therefore it won't happen. If you want the patient's medication changed, if you aren't documenting that and communicating that properly to the GP, then it isn't going to happen. And without wishing to sound mercenary about it, and depending on how your services are commissioned, if you aren't documenting your activity, then you are not getting remunerated for it. And whether you're block contracted or whether you're paid by a clinical interaction, if you're not generating some sort of output from your telephone consultations and things, then actually people will want to know what you're doing, and you can't prove that you're doing it. What was news to me recently was that there were a couple of guidelines about how we write letters. And I just, I'm interested, I know we've got a sort of a Q&A function, haven't we? I'm just interested in whether anybody has A, come across these, or B, followed this. So the first one was the Academy of Medical Royal Colleges have a guidance document in the last couple of years about how we write our letters, and that we should consider the default being that we write all our letters directly to patients, copying in the GP, rather than writing to GPs and copying in the patient. And that obviously necessitates a rather different structure to the letter and slightly different language. I've tried this on occasions, and it's always felt a little bit contrived and clunky. So I'm gonna keep going back to it every now and again until I get it right, I think. But certainly the Academy of Medical Colleges seems to think it's a good idea. I also would recommend that you have a play about on Microsoft Word with your clinic letters if they're in that format. There is a readability function that you can generate from one of the editing tabs in Word. I'd like to be able to tell you exactly how to do it, but I can't remember now off the top of my head. But it'll generate a readability score for your clinic letter, and it'll tell you exactly how penetrable it is for a patient. But I think that's quite interesting. I was a bit horrified at how readable my ones were this week. It also gives your letters a reading age, like a child's reading age, and the recommendation is you should aim for a reading age of between 8 or 9 for your clinic letters. The reading age of my last letter this week was reading age of 10, so I thought it wasn't too bad. But yeah, it's interesting. Just to try this because I think the information has to be perceptible to the person receiving it. The other thing, which is actually completely contradicts what I've just said, oddly, is the PRSB guidance on how to structure a clinic letter. That doesn't mention anything at all, as far as I can see, about writing directly to patients, but has a very sort of clear kind of structure for how our outpatient letter should appear. And having shown this to my litmus test is to show this to my wife, who's a GP. I showed her the outpatient letter standards, and she said they're unreadable. So I'm not sure that's a great standard for us to follow, but I would recommend you having a look and seeing whether there's anything that you can take from those in terms of your documentation. And then last but not least, I think in terms of looking at our services and the change that we've been through, we're talking about changing medication for patients, but we've been through a lot of change ourselves. And I think one of the things that might be useful for us to do as individual services is have a look at how we're actually doing at the minute. What is our waiting time for new referrals at the minute, and how does that compare to pre-pandemic? What's our waiting time for review patients? And I think we're struggling a bit for new referrals, particularly. What's your current face-to-face capacity? What's your current service template, and how has it changed? If you want to know about the impact of COVID on your patient group, have a look at Parkinson's admissions year on year.
I think for both you and Viv, Neil, there's been applause from the delegates. They seem to have really enjoyed what you've had to say. There are no questions as yet, but we had a question that came in earlier, which is in the face-to-face consultations, very often the person with Parkinson's comes with their next of kin and their loved one, and sometimes you get two different stories playing out in front of you, don't you? How does that work now in the digital world?
Well, I mean, I've had a really nice example of it working quite well with a video consultation recently. So there's a chap actually with dementia with Lewy body diagnosis fairly recently that we saw, and it was quite difficult in the hospital because everybody was masked up in the clinic when we did the diagnosis. It was done in a sort of slightly weird ward environment in a treatment room, quite socially distanced, and it felt odd. And I just knew that there was a lot of stuff that we hadn't got into in that consultation. So we did a video consultation, and we had to, and we had to improvise. Like attend anywhere was hopeless. I ended up basically just FaceTiming them, which is completely not what you're supposed to do. But anyway, and it worked incredibly well. They were really relaxed. They were sitting on their sofa. They were having a cup of coffee. We could all see each other's faces. And actually, I think because we'd had sort of both bits of it, the kind of a bit of face-to-face and then the video stuff, I think it worked quite well that second time round. But it's a huge challenge. And there's a chap up in Glasgow called Ed Newman, who I know Diga, who's a Parkinson specialist, and he's for years covered the Western Isles remotely as a Parkinson specialist. And I think he would just say sometimes it isn't possible to do it well remotely, and sometimes you just have to bring people to see you, and I think that's the deal, isn't it? I think that's, and I'm sure Hannah and Viv would probably have maybe have other thoughts, but.
So a question's coming from Jamie Doherty. How are you approaching advanced planning and these difficult conversations virtually rather than face to face?
That is really difficult, I think. I mean, Jamie, all I'd say is we, with a bit of luck, we know these patients really well by the time we're getting to the point of having to have advanced planning around, dementia, psychosis, or even kind of last weeks, months of life. And you can do some of that. It's not ideal to do it by phone at all. And, like we've all got that. Yesterday, I was ringing somebody from a ward with a very ill Parkinson's relative on the ward that I'd been up to see, and it was done by phone, and it went okay, I think. But we know the patient, and his daughter knows I know him, and I've been up to see him. So I think it's if you've got that kind of connection to begin with, that's it's possible to do it well in this kind of situation, but it's not easy, not at all, I don't think.
So Jen Pigott asked, how long are your appointments now when they're virtual, and how does that compare to what was normal?
I feel like I'm monopolizing the floor. We haven't really
No,
changed
that's
we haven't changed the duration of appointments particularly. We are seeing fewer face-to-face ones, and so sometimes that tends to expand a little bit. Our Parkinson's advanced symptoms unit, for example, we used to see 6 patients in a morning in that specific kind of more complex clinic. We now see 4 in the morning and 2 in the early afternoon, so we can space them out a little bit. We had a sort of anticipated doing remote stuff in between and things, but it's, actually some of it's so complicated right now that we really just need to spend the extra time, I think. We haven't changed. So the template's reduced, definitely. But I've always felt it takes as long as it takes.
Absolutely.
Which is why my clinics are always a disaster.
Well, they're not. They're award-winning. So Linda Moss has asked, and I'll ask you, Viv, as well, are there things that you're going to keep after we go back to the new normal?
What do you think, Viv?
Putting you on the spot there.
Yeah, definitely. I mean, I think there's definitely bits that have been really helpful. I think, as Archie's saying, like it's really important to get to know people, and I think probably if we're going to be giving diagnosis, that's probably best done face to face. But actually, some of the follow up from that can potentially be done over the phone or sort of with the video call. And yeah, I think there's maybe just having that flex and a mixed approach and asking sometimes. So some of the work that our wonderful nurses have been doing is kind of before clinic, a couple of weeks in advance, asking what people's preferences are and trying to accommodate those as best we can.
Yeah,
brilliant.
And I think
Thank you.
I did one clinic. I mean, this was an exception, but I did a clinic by video months and months ago now, where I traveled 768 virtual miles in the clinic. Now that was a couple of out of region referrals for second and third opinions, but that's clearly an advantage to hang on to that idea that patients can be well out of your region and still access some input. And also I was thinking about this today because one of my patients is moving to Norfolk soon, and they aren't linked up with anybody just yet. And that idea that they can then still access our service seamlessly and remotely, either by video or telephone, until such time as they are under the wing of another team, I think that's quite a nice thing to be able to offer people at the minute.
Yeah. So last 2 questions, I'm going to merge them into one from Deb Evans and Kate O'Kelly. So Deb's asking about how you're managing memory reviews virtually and whether or not you feel the mocker is essential. And then Kate is asking about seeing people whose mental health is deteriorating in lockdown, and any tips that you may have around that. And lastly, what meds are you confident reducing or stopping? So just a small thing.
Yeah, but I mean, with respect to the first bit, I absolutely bow down to Deborah Gallant, our OT. So Viv's nodding, right? Yeah. So we saw somebody this week with significant cognitive issues, and it's difficult to do. Like the mocha, we've been doing like the blind mocha on the phone. I guess a lot of people have been maybe using that a little bit, but actually, the scores on the doors on a cognitive test, X out of 30, are sort of meaningless in a lot of patients with PD dementia because it fluctuates a lot. And really what you're more interested in is the functional impact of cognitive problems. And that's where Deborah's been amazing. And there's a huge amount of information that you can get remotely on, from talking to a patient, talking to a spouse about things that they used to be able to do that they can't do now around finances, using computer remote controls, cooking appliances, you know, looking after their own medication, going down to the shop to get the paper. Like there's a whole host of kind of functional cognitive tasks. And actually that sort of information is probably far more useful anyway to you. And I'm quite happy making a diagnosis of Parkinson's disease, dementia, for example, based on that sort of functional information. I don't really care what the MOCA score is. And I think in that sense, we're happy to, you know, like we recognize that that's a big issue, and we've seen a lot of cognitive decline with social isolation, you know, with the lockdown and social isolation. I think if you ask yourself the question, it goes back to like Viv's point, like what are you trying to avoid? Right, like if you've got a patient who with a developing dementia syndrome, maybe with some psychotic features, and they're at high risk of admission to hospital, well, like hospital's the last place they need to be right now. It's just so they can't even get a visitor in a lot of places, and you know, so actually anything you can do to keep a person out of hospital is worth seriously considering. And it might feel a bit uneasy to commence medications like, for example, cholinesterase inhibitors. We've done a fair amount of remote prescribing of those. We don't have any real qualms about doing that, because I think if the patient responds well to that, then you might be reducing their risk of an unscheduled admission to hospital, and that seems like a good thing to do. So, I mean, I don't know if that answers the question, but I'm pretty. There isn't much I won't have a crack at remotely. What do you think?
Well, thank you very, very much again, Archie and Viv.